Pulmonary embolism. Introduction. The blood flows from heart to lungs through pulmonary artery. In the lungs the blood is supplied with oxygen, then it goes back to the heart, which pumps the oxygen-rich blood to the rest of body. When a blood clot gets caught in one of the arteries that go from the heart to the lungs, it's called a pulmonary embolism, PE. The clot blocks the normal flow of blood. This blockage can cause serious problems, like damage to lungs and low oxygen levels in blood. The lack of oxygen can harm other organs in the body, too. If the clot is big or the artery is clogged by many smaller clots, a pulmonary embolism can be fatal. The embolisms usually travel to the lungs from a deep vein in the legs. It is called deep vein thrombosis, DVT. These clots develop when the blood can't flow freely through the legs because the body is still for a long time, during a long flight or drive, or someone is on bed rest after surgery or illness. Definition. Pulmonary embolism, PE, is when a blood clot, thrombus, becomes lodged in an artery in the lung and blocks blood flow to the lung. Pulmonary embolism usually arises from a thrombus that originates in the deep venous system of the lower extremities. Pulmonary embolism, PE, is a blockage of an artery in the lungs by a substance that has moved from elsewhere in the body through the bloodstream, embolism. Pulmonary embolism is a common disorder that is related to deep vein thrombosis, DVT. Pulmonary embolism refers to the obstruction of the pulmonary artery or one of its branches by a thrombus that originates somewhere in the venous system or in the right side of the heart. Classification. The pulmonary embolism can be classified as thrombotic pulmonary embolism, non-thrombotic pulmonary embolism. Risk factors. Medical conditions. Heart disease. Cardiovascular disease, specifically heart failure, makes clot formation more likely. Cancer. Certain cancers, especially brain, ovary, pancreas, colon, stomach, lung and kidney cancers, and cancers that have spread, can increase the risk of blood clots, and chemotherapy further increases the risk. Women with a personal or family history of breast cancer who are taking tamoxifen or raloxifene also are at higher risk of blood clots. Surgery. Surgery is one of the leading causes of problem blood clots. For this reason, medication to prevent clots may be given before and after major surgery, such as joint replacement. Disorders that affect clotting. Some inherited disorders affect blood, making it more prone to clot. Other medical disorders such as kidney disease can also increase risk of blood clots. Prolonged immobility. Bed rest. Being confined to bed for an extended period after surgery, a heart attack, leg fracture, trauma or any serious illness makes patient more vulnerable to blood clots. When the lower extremities are horizontal for long periods, the flow of venous blood slows and blood can pool in the legs, sometimes resulting in blood clots. Long trips. Sitting in a cramped position during lengthy plane or car trips slows blood flow in the legs, which contributes to the formation of clots. Other risk factors. Smoking. For reasons that aren't well understood, tobacco use predisposes some people to blood clot formation, especially when combined with other risk factors. Being overweight. Excess weight increases the risk of blood clots, particularly in people with other risk factors. Supplemental estrogen. The estrogen in birth control pills and in hormone replacement therapy can increase clotting factors in your blood, especially if you smoke or are overweight. Pregnancy. The weight of the baby pressing on veins in the pelvis can slow blood return from the legs. Clots are more likely to form when blood slows or pools. Pathophysiology. Obstruction. When a thrombus completely or partially obstructs the pulmonary artery or its branches, the alveolar dead space is increased. Impairment. The area receives little to no blood flow and gas exchange is impaired. Constriction. Various substances are released from the clot and surrounding area that cause constriction of the blood vessels and results in pulmonary resistance. Consequences. Increased pulmonary vascular resistance due to regional vasoconstriction leading to increase in pulmonary arterial pressure and increased right ventricle workload are the consequences that follow. Failure. When the workload of the right ventricle exceeds the limit, failure may occur. Clinical manifestations. Common signs and symptoms include shortness of breath. This symptom typically appears suddenly and always gets worse with exertion. Chest pain. Feeling like having a heart attack. The pain is often sharp and felt when breathed in deeply, often stopping client from being able to take a deep breath. It can also be felt when cough, bend or stoop. Cough. The cough may produce bloody or blood-streaked sputum. Other signs and symptoms. Rapid or irregular heartbeat. Lightheadedness or dizziness. Excessive sweating. Fever. Leg pain or swelling, or both, usually in the calf caused by a deep vein thrombosis. Clammy or discolored skin, cyanosis. Assessment and diagnostic findings. Death from PE commonly occurs within 1 hour after the onset of symptoms, therefore, early recognition and diagnosis are priorities. History taking, complete medical and surgical history, environmental history, personal history, medicine, history of trauma. Physical examination, chest auscultation, rapid breathing, level of consciousness, cyanosis, peripheral edema, assessment of sign and symptoms, jugular vein distension. Chest X-ray. The chest X-ray is usually normal but may show infiltrates, atelectasis, elevation of the diaphragm on the affected side, or a pleural effusion. ECG. The ECG usually shows sinus tachycardia, PR interval depression, and non-specific T-wave changes. ABG analysis. ABG analysis may show hypoxemia and hypercapnia, however, ABG measurements may be normal even in the presence of PE. Pulmonary angiogram. Pulmonary angiogram allows for direct visualization under fluoroscopy of the arterial obstruction and accurate assessment of the perfusion deficit. VQ scan. The VQ scan evaluates the different regions of the lung and allows comparisons of the percentage of ventilation and perfusion in each area. Management. Medical management. Because PE is often a medical emergency, emergency management is of primary concern. Anticoagulant therapy is the mainstay of treatment. Acutely, supportive treatments, such as oxygen or analgesia, may be required. Anticoagulation therapy. Heparin and warfarin sodium has traditionally been the primary method for managing acute DVT and PE. Thrombolytic therapy. Urokinase, streptokinase, alteplase are used in treating PE, particularly in patients who are severely compromised. Oxygen therapy. Analgesic. Surgical management. Removal of the emboli may sometimes need surgical management. Surgical embolectomy. This is the removal of the actual clot and must be performed by a cardiovascular surgical team with the patient on cardiopulmonary bypass. Transvenous catheter embolectomy. This is a technique in which a vacuum-cupped catheter is introduced transvenously into the affected pulmonary artery, interrupting filtering the vena cava. This approach prevents dislodged thrombi from being swept into the lungs while allowing adequate blood flow. Nursing management. A key role of the nurse is to identify the patient at high risk for pulmonary embolism, and to minimize the risk of PE in all patients. Nursing assessment. All patients are evaluated for risk factors for thrombus formation and pulmonary embolus. Health history. Health history is assessed to determine any previous cardiovascular disease. Family history. History of any cardiovascular disease in the family may predispose the patient to PE. Medication record. There are certain medications that can increase the risk for PE. Physical exam. Extremities are evaluated for warmth, redness, and inflammation. Diagnosis. Based on the assessment data, the following nursing diagnoses for a patient with pulmonary embolism are developed. Ineffective peripheral tissue perfusion related to obstructed pulmonary artery. Risk for shock related to increased workload of the right ventricle. Acute pain related to pleuritic origin. Nursing care planning and goals. Planning and goals for a patient with pulmonary embolism include the following. Increase perfusion. Verbalize understanding of condition, therapy regimen, and medication side effects. Display hemodynamic stability. Report pain is relieved or controlled. Follow prescribed pharmacologic regimen. Nursing interventions. Nursing care for a patient with pulmonary embolism includes: prevent venous stasis. Encourage ambulation and active and passive leg exercises to prevent venous stasis. Monitor thrombolytic therapy. Monitoring thrombolytic and anticoagulant therapy through INR or PTT. Manage pain. Turn patient frequently and reposition to improve ventilation perfusion ratio. Manage oxygen therapy. Assess for signs of hypoxemia and monitor the pulse oximetry values. Relieve anxiety. Encourage the patient to talk about any fears or concerns related to this frightening episode. Evaluation. Success of the treatment plan will be evaluated with the following: increased perfusion, verbalized understanding of condition, therapy regimen, and medication side effects. Displayed hemodynamic stability. Reported pain is relieved or controlled. Followed prescribed pharmacologic regimen. Prevention. For patients at risk for PE, the most effective approach for prevention is to prevent DVT. Avoid venous stasis. Active leg exercises, early ambulation, and use of anti-embolism stockings are general preventive measures for DVT. Sequential compression devices. These are plastic sleeves that can be inflated with air for compression and relaxation of calf muscles. Mechanical prophylaxis. Mechanical prophylaxis can be classified as static or dynamic. Graduated compression stockings. This involves the sequential movement of air in the sleeve up the leg, followed by relaxation of the sleeve. Anticoagulant therapy. Anticoagulant therapy may be prescribed for patients whose hemostasis is adequate and who are undergoing major elective abdominal or thoracic surgery. Complications. When caring for a patient who has had PE, the nurse must be alert for potential complications. Cardiogenic shock. The cardiopulmonary system is endangered in a massive PE. Right ventricular failure. A sudden increase in pulmonary resistance increases the work of the right ventricle.